Okay, good afternoon, ladies and gentlemen. I'm Dong Choi from Yonsei University Severance Hospital, and I'm the chair of this live case session 4, and my co-chair is Yoshiaki Yokoi.
Welcome. We have 2 cases from Asan. Shall we get started?
Yeah. Okay.
Dr. Basin, could you introduce the case?
Yes, good afternoon. Thank you for transmitting in to us here. I'll hand the case review over to my colleagues here. It's a iliac CTO. We think recent clinical CTO in a 73-year-old male. I'll let you take over from here.
Okay. Let me introduce the brief case of my case. 73-year-old male was referred to outpatient clinic claudication of right leg for 3 years, but his symptom was developed within 3 months, years aggravated, and claudication was developed 105 meters and gradually worsening. And CT scan showed the total occlusion of right common iliac artery with somewhat calcification. And past medical history is nothing. And next. Next. And we have 2 PTA with right CIA, and we you can show that.
So we also have an outside CT. I don't know if that can be shown.
Outside CT
Because yes, if you can walk through that, what you can see here is this is a heavily calcified common iliac CTO with eccentric calcification extending down. If you can scroll down, just keep going down. Really complex calcification until it reconstitutes just above the internal-external iliac bifurcation. And then if we can go to the angiogram here, what we have done so far is just put a 7 French sheath in the contralateral left common femoral artery, and we've done a power injection angiogram. Is that displaying for you there? Can you see our angiogram?
Yes,
Yeah, we clearly see the angio and relatively short occlusions with the stump. And what's your strategy?
So we thought we would try to approach this retrograde first. We have a 5 French sheath in the right common femoral artery. And because of a relatively late start and room turnover, we're just getting started. So what I've done is I'm just probing now with a V18 wire using a CXI from the right femoral. It's low profile systems, relatively atraumatic, to see if the distal retrograde entry is soft or hard.
Okay, Robert, we can see clearly the CT and the angio, and we have a panelist, and we will discuss the treatment strategy of this patient. Is it okay?
Yes.
Yeah. CT shows clearly calcification, but how about thrombus in the region? You can see the thrombus in the region or not? No.
5 French diagnostic catheter, maybe stiff straight glide.
Okay. Do you want to?
Robert, the CT shows some thrombus in the region or no thrombus?
Yes. Well, it's occluded, so it's difficult to say, but it's, as you can see, there's heavy calcification and then it's all gray, so it's difficult to say how much of that is plaque versus thrombus, but it's clearly occluded from the proximal stump to the point of reconstitution, and how much of that is plaque, I can't say, but there is a lot of calcium. It's very heavily calcified.
Dr. Ida, your treatment strategy?
I think this type of region is very difficult to cross because we found a very severe calcified ulcer iliac.
We can try.
So I think the difficulty of revascularization is depending on the present severity of the calcification and also the torsosity of the iliac artery. So my opinion, I think that by directional approach from the right brachial artery coaxially and the retrograde ipsilateral the common femoral artery.
Integrate means contralateral or brachial?
No, right brachial.
Brachial.
Brachial artery. Maybe it's very coaxial to close the region.
If you want to do the brachial arteries, which side do you prefer, right side or left side?
I prefer the right side because if we select the left side, it's maybe the
Another settings is
and
required.
yes.
So I would agree with brachial access here if we cannot make progress in other ways. The arm is not prepped yet, but
You have the CXI 4 French or 2.6?
this is a 2.6018. I think we're making good progress here. And what we have done is switch to an Asahi 25 gram.
Is that the outside the vessel or inside?
But
the
it's
vessel?
possible it is. It's possible. I don't think so, but we will see. Okay, so why don't we go off of overlay and take another run, see if we have blood return. Oh no, just a syringe, flush. And then let's take this
So
off
all the
overlay.
members retrograde approach first or the antegrade first? Any comment for
Can we
that?
remove the roadmap? Roadmap off.
So my strategy is antegrade and retrograde access, but in this case, so I try to retrograde approach from the right common femoral approach,
so that looks like it is DA.
or 40-inch guide wire,
Yeah,
taper
it's
guide
DA
wire,
left. So,
with the IBUS or the
can we have
support
the wire
catheter.
again?
Wire.
Maybe very short region.
25,
We
Asan.
prefer more magnified view because calcification is quite visible.
Ordinarily, I would approach this at least probably a half an hour before live, but we really only got a chance to start a couple minutes before. We just got Shisen before he arrived. So you get to watch the entire approach to this live. I inquired beforehand if we had either tour guides or destinos to do an up and over maneuver with guide support, and which would, I think, make it a lot easier to negotiate this relatively narrow bifurcation. But we don't have those here, so it's looking like going brachial may be the best solution if we cannot succeed this way. So the Torker, please.
So I'd like to comment on one thing. So, I'm Dr. Lee from Chungnam National University Hospital. And 여기 있어요, 여기 선생님 앞에 audience. I personally do this kind of CTO reason by transradial and ipsilateral femoral approach, not transbrachial. But because we have a long, slender shuttle sheath, 110 cm, that is reached to the aortic bifurcation. So transbrachial is not needed. So transradial is very good option for this kind of region because of perpendicular, it's also common iliac artery ostium is very short, but backup support will be poor from the contralateral femoral approach. The second thing is both antegrade and retrograde approach can be done, but both wires should be inside the CTO segment. Do not extend the CTO segment proximally or distally. That is very important. If this wire is past retrogradely, but wires past the distal tip of the stem, not distal tip of the stem, or more proximally, I will do antegrade again to make a meeting at the CTO segment.
No. Okay. Well, this calcium, as you saw, is very complex and eccentric, and it's deflecting me off. So I think we'll try a little bit longer here, but then we may switch over to an antegrated up and over approach here shortly. But it's definitely deflecting us. And we ran through the CT fairly quickly, but there's one segment where it becomes quite eccentric. And I think we have to do almost like a spiral turn to get around it, which may make it really hard to do retrograde. So we'll continue here because if it goes, it makes life easy. But if it doesn't, we'll switch over.
I think the iliac intervention is also important point is safety.
take another picture
so
here.
I usually prefer
On DSA.
antegrade approach, like Dr. Ida, the brachial approach or contralateral antegrade.
Even a
Yeah,
contralateral.
either way. But
the patient hold
I
his
think so. Most important
참으세요.
point
숨
to
참으세요.
wiring in the intraluminal, not the subintimal, especially this kind of the heavy calcified iliac artery. So I usually prefer antegrade approach.
So
Maybe
you
this type of region, each operator has its own opinion. So 20 or more different approach.
Really?
But
Well,
I think
whenever
definitely it's about time to change to the antegrade approach
Right.
for maybe the wire going in the false lumen and whatever you do, just creating a false lumen. So
Right.
it's time to change for the.
Yeah, I would agree. This has been deviating repeatedly. So I'm just gonna. So what do we have here in the laboratory for up and over access? Do you have a tightly curved? I think IMA guide might be the one thing you have.
After wiring, what kind of a treatment we can use?
I would say here covered stent. This is a complex total occlusion calcified. It's a TAS C to D. I think covered stent would be a very good choice here. Nope, I see it's deviating again. Okay, so I'm going to make, while I'm waiting for a guide catheter, do you have a memory, or what do you have for tight up and over? Memory guide catheter?
I am guide 65 centimeters.
60, do you have a
it's
65
French,
cm
it's,
short IM, like renal guide?
그 앞에 이것은 걸 이제 물어보신 건데.
Yeah, Destino or a tour guide would be ideal here, but we don't have that.
In this case, I think that contralateral crossover access is very, very difficult because of the very short stump and the angle is very so narrow. So.
Yeah.
This is promising here. Let's
But
see.
they are not prepared for a brachial, so
Yes,
for
brachial
one try,
aneurysms, yes.
could be a.
No, not yet. If need be, we can prep for that.
So, Dr. Choi, so what
this
kind of
is
covered stent
feeling
do
good.
you have in Korea? So I found that live stream implantation for common iliac artery
and,
live demonstration.
We have a Korean company,
Korean
SNG,
company?
but SNG, the stent graft is mainly focused on the limb.
Limb.
Yeah, EVA, for limb for the EVA, so it is not special for this kind of iliac
So you mean
artery.
that some of this stent have not enough have a good radial force or
Right,
scaffolding?
yeah.
But we have
Go company withdraw their whole product, so we have a very limited choice.
they say we will the bar the live
Why don't we
stream
leave that there?
will be
Do
a
you have
better
the
version.
Lima?
Yeah. So this
Live
case
stream and SNG. Yeah.
live stream from the bar. Yeah.
Live stream is a
Cover stent.
self-expanding cover
Balloon
stent.
expandable.
Balloon expandable cover
Yeah.
stent. Because we found the very severe calcified region.
Yeah, that is
This
indicated
is
for
a
this
good
case.
indication for live stream.
I think maybe I just got it. Wow. Yeah, I think we're through.
Wow. Excellent job.
Well, I can tell you from the tactile feel, this was heavily, heavily calcified. This was a 30-gram Estado wire, and it was giving a lot of resistance. But I believe we're through. We have nice blood return. Okay. Let's now take a support 018 wire. Do you have a just
Dr.
extra
Bassi?
support?
Dr. Bassi? So I have a comment about the recanalization point. So should we perform the IVAS for just assessing the osteal recanalization point?
Honestly, I think I'm through the true lumen the whole way on this approach. It followed really nicely. You can see it's following the calcium channel the whole way. I feel pretty comfortable now to do a small balloon pre-dilation. I had good blood return, very good blood return, easy, just aspirating the CXI after crossing. So let's go ahead and wipe this down. Let's just have like a 3 millimeter by, do you have a long 3 millimeter?
3짜리.
Like 60 or
Sometimes if the wire past the proximal portion
short wire?
can be not be
Short wire?
expected after
This is
subintimal
200,
space.
right?
So Dr. Ida's mention is very important. So simple way to check the entry point of guide wire is a rotational
short
angiogram. During injection of contrast, rotational angiogram can make good image.
We need to put something in for CXI. Yeah, put that in.
First, and
Yes. So we just put the V18 in, but that's a short wire. So we're just going to do a quick exchange with the CXI to get an exchange length support wire in. And then we're going to balloon this and do an angiogram.
Actually, in Korea, IVAS is not reimbursed, but after introduce Dr. Ida's recommendation of IVAS in the, especially very complex lesion. Today is like today instant resonance lesion. Yeah. We did IVAS and we learned very much very good information. So I think the very complex lesion, this kind of heavy calcified iliac artery and instant restenosis. I think the IVAS is very helpful and very informative.
Okay.
So we find the moderate stenosis the left side. So how do you manage the osteo? Just a simple stent for right side or kissing stent technique, or we have to discuss about this point after success wire crossing.
And above the vessel size, it's a little bit small
Small.
for the common area on these patients. Not a 10 or 12, but around 8.
Yeah. And also, heavy calcified region, CT scan overestimated the vessel size, so we cannot clearly find which vessel size is correct by the CT scan. So I think the IVAS is very helpful.
It's my gut one. Okay, we're about to dilate here. Balloon's going in. We have a 30 by 80, I think. 018 balloon.
So after improvement of covered stent, you want to implant the covered stent primarily in this type of region?
Do we have IVAS?
No,
Do we get
because
IVAS, right?
I have no experience of live stream, and Korean SNG cover stent is also not familiar for this kind of region, so I prefer diameter
Get ready
stent.
to go up.
So you mean the traditional but expandable stent?
Yes, yes.
do you want a 7?
Okay, we're going up with the 3 millimeter balloon. Just go up to rated. Okay, store that image. Okay, you can come down. Let's go ahead now and do an angiogram. I would march the balloon out. We may have to dilate one more time, a little lower. Go up one more time.
Okay, there's no
Beautiful.
resistance.
Okay, store that image and come down. All right, let's exchange the balloon out so it doesn't block flow. It's a small channel.
Okay.
Yeah, wait a moment.
Then check it.
Okay, have the patient hold his breath.
어르신 숨 참으세요.
Not enough to get flow, but you can sort of see a little flow beginning. I was very comfortable with that. Maybe we go just a little bigger. What I would suggest at this point is let's go with do you have a 5 millimeter balloon?
5.
We're going easy here. We're just making a big enough channel to make sure we have good flow. Yes.
We have to move, you did a nice job already. So we'll move to the another rooms and we'll be back soon. Okay?
Terrific. Yep, thank you.
Check the angle?
Angio?
Or
Oh, no.
Dr.
Because,
Ando?
if there's some debris, you can go, the debris can be embolized, so we have to
Dr. Ando
remove
and
it.
Dr. Lee?
Okay.
okay.
Dr. Ando, can you hear me?
Oh, yes, we
Oh,
can hear you.
Yeah,
Sorry.
okay.
Choi sensei,
We were-
hello.
Okay, please introduce your case and your team.
Okay, thank you. I'm Hiroshi Ando from Saitama, Japan, and it's a great honor to be given this opportunity. So with me, Dr. Lee will help me this time. And could I have a case presentation?
Okay. We'll introduce our case here. This patient is a 75-year-old male patient, and he presented to our clinic because of a severe claudication. So he has a history of hypertension, diabetes, and he has a chronic kidney disease, which may be an issue in this case. And he previously received the iliac stenting at the left portion 1 year ago. So his ABI was 1.52 at the right, 1.64 at the left. And next please. So we'll show you the CT angiography, which was taken in another hospital. CT, please. So you can see that there is a stent at the left common iliac artery. That's not a calcification, that's a stent. And show you the cross-sectional image. Because there's lots of calcium, the volume rendering has some limitation. You can see, you focus on the left, there's a stent, it looks patent.
Yeah.
But at the distal end of the stent, you can see some stenosis. It looks severe. And it's common femoral. There's lots of calcium at the ostium of the SFA, a little bit lower. So this was the CT finding, and a little bit lower for the right. If you focus on the right of the SFA, there's a diffuse, moderate stenosis. Go down, go down. A little bit down. And there's a total occlusion at the right popliteal artery. It's a bit more down. Little more down. Right there. Okay, so we have an issue. We have severe stenosis at the distal edge of the previous stent. And there's a severe calcification at the ostium and proximal portion of left SFA, and there's a total occlusion at the right popliteal artery. So this is our situation.
So, which is your target?
So today's target is the left side of the left side. I mean the external iliac artery and SFA. And I'd like to show. Is it okay? Move. So
Okay.
I'd like to show you the procedure we've already done so far.
Okay.
So
This is the first view.
this is the first angle. You can see severe stenosis at the EIA. And first of all, we check the pressure gradient here using using catheter, and the pressure. Can you see the pressure gradient?
Can you show them the pressure? Okay.
So, no.
They can.
So there's about 40.
There's about 40 millimeter mercury difference between the EIA lesion.
Okay.
And the next, please.
Okay.
And there is a problem that the bifurcation of the aorta is a little bit high and a little bit sharp. So next. Next. I exchange the wire to the stiff wire. This is here we can check the pressure gradient.
Yeah, this is where we took the pressure gradient.
Next.
Next.
The next. And using balloon anchoring technique, I introduced the 6 French guiding sheath upon the cross. And then next, into the stiff wire into the SFA. Next.
Okay.
And exchange to the 7 French. This is 7 French.
Yes,
right?
this is 7 French.
7 French answer sheath. And then this is angio. You can see severe stenosis at the orifice of the SFA with severe calcification. So this is our case today.
What about the common femoral?
Yeah, so there's a stenosis here, so I will treat here too. Yokoi sensei.
Hi, Ando sensei.
So,
what you have done so far?
Okay, so let's show we conducted to cut the calcification using Tomahawk, Hawk one.
Hawk one, right?
Brand new one. So first of all, and at first, I put the filter device, spider device, 5 millimeter, and then next, this is Tomahawk, and I cut the common femoral, left side of the common femoral, and the left side of the SFA. So I cut this region several times using Hawk one device.
Did you check IVUS before the atherectomy?
Oh,
IVUS?
No, we did not.
No. Okay, check the angio.
Okay, this is our current situation. We'll just check the angio.
Yeah, check the angio.
Okay.
Quite good.
Much better.
Yeah, much better. And next idea is to open using balloon and put DCB. What do you think?
Any comment over the atherectomy devices? You don't have
DCB have the
experiences.
Yes. So Dr. Ando, so this is Dr. Fujihara speaking. So I know the DCB have some limitation, especially in the heavy calcified region. So how about what do you think about this calcified region? DCB that work for these heavy calcified regions?
So that's why I prefer to use Tomahawk at first, and then I'd like to use DCB. That's why we
before you apply DCB, do you do more balloon angioplasty for high pressure?
Yes. Maybe the vessel preparation is very important. So I'd like to open this area using 5 millimeter, 6?
6, maybe 6. Yes.
Dr. Ando. Dr. Ando.
Can I have a balloon? Yes.
Okay.
I'm Dr. Lee from Gangwon National University Hospital. This region also looks, the jet stream looks feasible for this region. And is there any region you choose Hawk one?
Because this area is the bifurcation region, and also you can see here eccentric calcification. So I'd like to choose a directional one.
So how about cutting a little bit more?
Okay.
Is it okay?
Okay.
We just
Let's
did
go.
about 3 or 4 times.
Okay, let's go another round.
Hawk one 주세요. Hawk one.
Dr. Ando,
Yes.
is there any difficulty to bring such kind of a device from the contralateral approach?
No.
No.
Yeah, very smooth. Maybe the profile is better than the old Turbohawk.
Yes.
The Hawk one is much better.
Hawk 1 has been significantly improved compared with the Turbohawk, and the shaft profile is 0.1 millimeter lower than the Turbohawk. So even if the angle of the bifurcation, aortic bifurcation is acute, it is better than the Turbohawk.
I have one crossing failure with the previous silver. At that time, the patient has a heavy calcified iliac bifurcation. Aortic iliac bifurcation. So at the time I failed and the silver was broken. Yeah. But the recent device is much better improvement. And if we cross the sheath, I think it is okay. But previous live Dr. Garcia using this device and several times cut, but patient complained pain and they found operation. So I think especially common femoral artery, I usually recommend very gentle and also recommend IBUS, because IBUS we can see clearly how can we cut and something. So
it's difficult to cut.
But mid portion of SFA, I think it is okay without IBUS, but common femoral is another.
So Dr. Cho, I have a brief question about the revascularization for common femoral artery. So in clinical setting, in general, common femoral artery is a good indication for surgical and atherectomy revascularization. So in Japan, we don't have the atherectomy device. We just discussed about the vascular surgeon. So how about the improvement atherectomy device? So common femoral arteries commonly performed by endovascular atherectomy device with the DCB?
Maybe it depends on the
hospital situation.
Yeah, but in several hospitals, we have very good relationship. So previous Garcia case, I prefer endoatherectomy.
Surgical
surgical endoatherectomy for common femoral but the distal part, SFA, I prefer the atherectomy. So at the case, we already have a safety information. So I first recommend the surgical endoatherectomy with simultaneously the atherectomy
with DCB
at the same time.
Okay. You have a good hybrid room.
Did you feel pain?
No.
No. Okay.
How about Dr. Kim? You are a vascular surgeon, so how about the atherectomy in this case?
Yes, usually when the patients need to save the deep femoral arteries, I always do the femoral endoatherectomy rather than some pocket techniques. But if there is a concomitant SFA, I do hybrid procedures. So femoral endoatherectomy is very stable.
The common femoral vessel size is fairly large. Even atherectomy devices may not catch the eccentric plaque. Am I right? Or it's possible to the cutting the
I think that even though you use percutaneous atherectomy techniques, there's always high chance to restenosis for the common femoral artery.
Yeah,
so
6 French.
I think
Six.
I want a more durable options.
Maybe
about surgical endoatherectomy.
60?
Yeah.
60? More than 60? So we did another atherectomy session, and we decided to apply a 6 millimeter 60 balloon for this lesion.
Okay.
So how do you think about stent implantation for common femoral artery? Because currently we have the TECO trial from France. Professor Yang Gufik presented that TECO trial. Just
I don't think it's a good idea. But some when I visit the Link meeting this year, some center they do some a randomized study with the super stent.
Yeah, Supera.
Yeah, but they say that is okay, but I don't agree yet the stent availability.
But I think it's depending on the patient background. It's very.
This patient is too high risk patient for the surgeries. We can recommend
You
some,
perform the
stent.
under general anesthesia or local anesthesia? For
endovacuomy. Usually under the general anesthesia,
so
but in emergency cases or the very high risk for the general, I do the local anesthesia.
This is
If
a
the
6
patient
by
condition
80.
is, patient age is very old and patient activity is
75.
not
75.
Higher activity, I think the stent at the common femoral is
so which type of
acceptable.
stent? Which type of stent? Supera?
Supera or the self-expandable stent is also
For the high risk
acceptable,
patients.
but highly activity person, I do not want to put the stent at common femoral.
Dr. Ida,
Hi.
so if you implant the stent here, so I mean the common femoral artery, what kind of stent do you use in Japan?
So I prefer the live stent or Innova stent, more flexible stent. But I just discussed with Dr. Gufik from the presenter for the tech trial. He implanted a Luminex stent for common femoral artery. Luminex stent, just comparing between the Luminex stent implantation versus surgical and atherectomy in JAK intervention. But interestingly, the result, 2-year result is almost comparable. Maybe some kind of scaffolding might be needed for acquiring the better patency for common femoral artery.
But this study, basically, the interventional have zero mortality, zero morbidity. So I think surgeon is very tough for this kind of the trial because interventional 30 days there's no mortality, no morbidity, and the surgical sides, there are certain complications.
Dr. Gufik is a vascular surgeon, but he said that I'm an endovascular surgeon, he said. Not a real vascular surgeon, like a Japanese style.
So how long?
2 minutes.
2 minutes.
Yeah.
2 minutes? Okay, down.
Down.
Check the angle, okay?
Can we see 2 views for after you completed laryngoplasty?
Okay.
Because
but there's a
eccentric
limitation
part
of...
may be visible by the angled
yeah.
view.
But his
we have a
renal
contrast
function
issue.
is not so good, actually.
So, okay.
Okay, let's go. Are you ready? Okay.
No.
Okay.
Yeah, the left one. Left one. Yes. It's the middle one. Okay. Oh, something is wrong.
Something wrong.
I'm sorry.
Okay.
Is it right? Okay.
Made by hand injection.
Oh,
good.
Quite good. But more angled views.
Okay. RL. Okay, let's go.
Okay.
How do you think?
I think it's acceptable.
Yeah, acceptable. Yeah, I think so. So maybe we have to put the DCB.
Yeah, I think so because we can see only minor dissection at the distal part. So I think the DCB is also a good option.
Okay.
So.
Okay.
Okay, Dr. Han, the next room is for transmission, so we will move and come back again. It's okay?
Okay.
Okay. 옆방으로 좀. 받아주세요. 네. Okay. Robert, we can see you.
Yes,
and,
hello. We're making very good progress. We're just now post-dilating. We'll walk you through what we have done.
What sort of stent, what and the size and the length?
Yeah, so when you left us, we had crossed and we were just pre-dilating with smaller balloons, 3 and then 5 millimeter. And then after the 5 millimeter, we went in with switched over to an 035 system, put in a long 7 French sheath, dilated it up more fully with a 6 millimeter balloon on an 035 system, and then placed this 7 millimeter by 60 millimeter LifeStream stent graft. And it's in good position, easy now, not too hard. And we're
7 millimeter diameter self-expandable stent, right?
No, LifeStream, it's a stent graft balloon expandable.
Stent graft.
Yeah, it's a long segment CTO. Now go easy here, just like 2 atmospheres. We're at the lower end here.
Okay,
2. And now we're post-dilating with a 9 millimeter balloon. Okay, that's good there. And he's had no pain throughout. Store that and come down.
Stop.
Usually self-expandable stent sizing is slight oversizing, but how about the stent graft?
Stent graft you want to
Same,
be appropriately sized, not oversized. Here, and now you can go bigger. This is bigger, this common iliac. You can go, what's the rated on the balloon?
Luminary 8. 4.
That's good there.
4.
Any pain?
No pain. No pain.
But common femoral 7 millimeter, bit too small.
Okay, now we'll give you an angiogram.
Also slightly smaller.
Okay, let's go ahead and, I think we'll just put the balloon higher up so we can use it again if need be. So it's out of view. And now we'll give you an angiogram.
환자분 숨 참으세요. 알아.
Have him hold his breath.
환자분 숨 참으세요. Ready, go.
It's quite nice.
Looking very nice. I'd say the ostium, there's a little plaque override at the very top, even though we're above the carina. You see that? There's a little lucency at the very top. I think that's just some residual plaque. I'm just going to dilate the ostium one more time to make sure the path is completely clear, and then we'll call it a day. Did you see that? The little lucency right at this proximal stent edge. All right, you can go up here. Let's go up to like 10. 6, 8.
How did you pick up the length of the covered stent? Because I tried to secure the internal or...
So what I did is I can show you, we did an angiogram after dilating the vessel with the 6 millimeter by 60 balloon, with the balloon in place to estimate length based on the length of the balloon markers. And it was pretty much exactly a 60 millimeter length. We were fortunate there we could do this implant with just 1 stent and not have to overlap 2. So we did an estimate of length using balloon markers.
It's a quite nice choice.
Okay, let's go ahead and march this out. I think the balloon can come out at this point, and we'll do a final picture. Balloon out. We'll just give you a final angiogram.
엔조 준비해주세요. 네, 레디.
Okay.
환자분 숨 참으세요. go.
Oh, very nice, I think. I'm satisfied. What does the panel think?
Yeah, very good. Very good angiography result.
Dr. Burstein?
Yes.
Can we make it bigger after we place the LifeStream balloon expandable stent? Because you put the how get bigger with the larger balloons? I heard that there's a limitation make it bigger.
There definitely is. I would say with the LifeStream, I have to look at the box on the 7 millimeter, but I think it's a maximum 10. We can look on the package and tell you, but certainly you have plus or minus 2 millimeters minimum with the LifeStream. And as I recall, the 7 can go to a 10. So it's it's okay. Here's your box, but there's no issue going 2 or 3 millimeters larger. So this expanded very well.
Okay.
Dr. Basin, how are you indicating covered stent in the iliac region?
Yes.
Not
I
only
think this one's clear. Heavily calcified total occlusion, CTO. That's a task C.
Yeah, this is a quite nice indication. What else are you indicate for?
So when you're for ISR,
ISR.
Yes, if you look at our recent appropriate use criteria for SCI, that was published in the past 6 months. The ISR lesions, task C and D's, CTOs, are all indicated. And of course, if you're performing re-entry, it's advisable. If you're having to re-enter into the aorta.
Do you see some differences between the live stream and the V12 stent graft? Use very similar platforms. Any profile difference?
Right. There's now 3: the iCast, the VBX, and the LifeStream. Of the 3, interestingly, the LifeStream and the VBX are the 2 that have iliac indication in the United States. The iCast has been around forever, but never did the prospective iliac trial to gain indication. But they all work well. I would say the difference is the VBX is designed to be flexible. The stent rings are not connected, so it's inherently more flexible. But both that and the LifeStream are balloon expandable. They have similar expansion ratios and profiles. There's minor differences here and there. But I would say the main difference between the 2 is the VBX is clearly the most flexible inherent in its design.
Thank you.
Thank you.
It's a great job and a great work and a great recanalization procedure.
Thank you very much.
Thank you very much.
Thank you.
So Anderson said, what's going on right now?
Okay, I've already done.
So we just
DCB?
used the drug-coated balloon.
Yeah, could you show the last image?
Okay.
So I use a DCB 6 by 100.
100.
100. What's the name of the?
Lutonix.
Lutonix. Okay.
Yeah.
And what is it? Is this a final image?
No.
After
this is
DCB?
not. Yeah, DCB.
This is an image of after DCB.
And we are changing the spider currently to stiff wire to treat the external iliac artery.
Okay.
Okay.
Here. Okay. There's no wire.
stiff wire 주세요.
And then we'd like to treat the iliac artery. Before that, I changed the wire to the stiffer wire, 035.
There was some material at the filter.
Can you see the filter?
Can we see the filter?
I will show you.
Can you show us the filter here? Yeah, we have some atheromas embolized in the spider. Can you see it?
Okay.
Right here.
Okay, let's go the stent.
Okay.
8 by 60.
8 by 60?
8 by 60.
Okay. What kind of stent do you want?
Oh, it's your call. It's up to you.
8에 60짜리 스텐트 주세요. 아니, 스텐트 주세요.
Can I say? You can get some debris.
Yeah. We can see.
And I'd like to put stent at EIA, 8 by 60. What kind of stent?
So,
I don't know.
Initial injury showed a very tortuous external artery with calcification. So how can you decide the stent length and the stent type?
So I choose maybe this region has calcification too. So I choose Codis, Smart.
Okay. So do you think 60 will be okay?
What? What length of this stent?
We don't have any information of the previous stent.
Maybe 60 will be fine from here to here.
Okay, okay. 60. So maybe we can take a picture and have a...
Take down you on the SFA?
Yeah, because... no. At the ilia? You're going to treat the ilia, right?
A60. You using balloon?
Yeah, A60.
No, it's okay.
Okay. What stent is it?
Smart.
So this stent is a smart control 860.
Yeah, A60.
A little bit short? Okay.
A little bit.
Let's go here. Okay, let's go.
Let's go. The proximal portion.
No problem.
Okay.
Store?
And
the 7mm balloon?
Yeah, 40.
Dr. Che, do you see the difference stand for the different iliac regions? Usually the epic is the most strong radial force for this Korean stand. And what's your preferred stand for that?
That is company data, not actual data. So I usually prefer this kind of region. I usually prefer smart stand because I have a lot of experience. But sometimes I believe the company data, but usually I don't believe company's data.
It's not objective. Dr. Ida, do you have a preferred stand for the iliac regions?
Smart.
But some company they say that Illuminate is most strong radial force.
Do you have pain?
But it
아픈지 좀 물어봐줘.
Pain? Okay, then stay.
Okay.
8? Okay,
Eight.
down.
Down.
The smart stent
He
is
has
only available in Korea and Japan.
Oh, really?
Oh yeah. Any other country? Yeah. Only Korea and Japan. So the rest of the people, they don't know what the smart stent is.
Here, pain, stop.
Yeah. 6.
Okay,
He has pain.
6. And the patient has a pain, so I stop dilatation at the 6 atmosphere.
But I think the code is a big sponsor for Encore,
definitely.
TCTAP and the JET. Don't say anymore.
We should promote smart.
Okay.
Okay.
Pull back the body.
Pull back.
Okay, thank you. I check down here. DA.
DSA.
DSA? Okay, stop breathing.
숨 좀 참으라고 해줘.
Yeah, maybe it's a
쉬시라고.
recoil.
Yeah,
No.
spasms, maybe spasms.
Spasm or accordion phenomenon.
Yeah.
What do you think?
Just
It's accordion. Yeah.
Take off the...
change the all 14 wires.
Right. Okay.
Right.
Oh, okay. Let's go.
Okay.
Okay, that's better.
Very good.
That's perfect.
Yeah. I think the stand position is very good because after if the doctor and choose a longer stand and cover the fraction side and make some dissection, but just exact length is very good. So
I can see
publicity.
lateral side.
Yes. Okay.
What shall I do? Is it okay?
So you wanna take a shot of the traffications
Yeah.
to check the distal
okay.
line?
Yeah, just a moment. Just a moment. Let's
We're
go
going to
DS.
this.
No, not DSA.
Cine.
Angle.
Cine.
Yeah.
Okay.
Let's go. Let's go. Let's go.
Okay.
Oops. Oh, sorry. This is the final angio.
He already has some
Yeah, very
below the
good
knee
result.
lesions. Yes.
What do you think?
Excellent result.
Thank you.
Thank you very much.
Thank you. Thank you very much.
Thank you. Thank you very much.
We had nice iliac and iliac CTO and the SFA calcified lesions. Looks like simple, but a very meticulous approach is required for even a simple lesions. So I learned a lot. Thank you very much for participating in this. We close this session.